Welcome back. My name is Osama Naga. We'll discuss in this section Pediatric Hematology Oncology Last Minute Review. You can follow with me in the Pediatric Board Study Guide Last Minute Review chapter Hematology Oncology section from page 592 to page 593. My objectives in this presentation: a quick and fast review before the exam to point out high yield points we must know to be able to differentiate between hematologic diseases with some similarities. We'll start with microcytic anemia. As you see in this slide, the size of red blood cell in the peripheral smear is less than the size of the nucleus of mature lymphocyte. If you have a child presenting with pica or interest to eat non-food items, ice craving, poor school performance or decreased cognitive function, attention deficit, looking pale, excessive intake of cow's milk more than 16 ounces per day, prolonged and heavy menses in adolescent girls. You decided to perform a CBC and reticulocyte count. You found that the hemoglobin is low, MCV or mean corpuscular volume is low, and reticulocyte count is low, and the RDW is elevated and the platelet is elevated. What is the most likely diagnosis? This is a classic presentation of iron deficiency anemia. The best initial test to order for any child with suspected anemia, CBC, and reticulocyte count. If the diagnosis is not clear, order serum ferritin, total iron binding capacity, transferrin saturation, free erythrocyte, protoporphyrin. If you have to choose to order only one lab, this would be serum ferritin. Comprehensive workup of iron deficiency anemia, the lab results would be low hemoglobin, low MCV and retic count, low serum ferritin, iron and transferrin saturation, and RDW would be elevated, platelet may be elevated, TIBC will be elevated. We do not have to order all these labs for classic cases of iron deficiency anemia. Classic cases of iron deficiency anemia, CBC and retic count. This would be enough to start the treatment. If you have a child with microcytic anemia, low hemoglobin, and serum ferritin is low, this is iron deficiency anemia. So you can go ahead and treat, and no further workup is required, except if the patient is not responding to iron therapy. It's critical to know the treatment of iron deficiency anemia. The dose of elemental iron is 6 milligrams per kilo per day, divided twice or 3 times a day. And it is advised to be given with vitamin C containing foods or juices, for example, orange juice. Very important to know the adverse effects of iron therapy: nausea, stomach cramping, constipation, or diarrhea. What are the labs do we need to order after treatment with iron? CBC and retic count. If you see in the follow-up that the hemoglobin and reticulocyte count, MCV, are increasing within 1 to 4 weeks of starting iron therapy, this is the best test to confirm the diagnosis of iron deficiency anemia. This means that we have to ask the patient to come back in 1 to 2 weeks of iron therapy, and we have to document the increase of hemoglobin and reticulocyte count. And we have to continue the iron therapy at least 2 months after the correction of anemia to replenish the iron storage. So bottom line, CBC and retic count, they are the best initial test, and they are the best test for the follow-up of iron deficiency anemia. A child presenting with microcytic anemia, low hemoglobin, the diagnosis was not clear. You decided to order more comprehensive workup, and the serum ferritin came back normal or high. TIBC was low, iron is low, and the transferrin saturation is low. What is the most likely diagnosis? Anemia of chronic disease. This is a classic presentation. The key point here is serum ferritin will be normal or elevated. Why? Because serum ferritin is a reactive protein and will be elevated in cases of acute or chronic diseases. Another case scenario: a child with microcytic anemia, normal or high serum ferritin, normal TIBC, normal or elevated serum iron, normal or elevated transferrin saturation. If you remember anemia of chronic disease, the serum ferritin was normal or high, but the TIBC was low, iron was low, and the transferrin saturation was low. This is not anemia of chronic disease. This is something else. These labs are suggestive of thalassemia. The best next step is to order electrophoresis. Minzer index is an excellent screening tool. It will help you to differentiate if you are dealing with iron deficiency anemia or beta thalassemia by just looking at the CBC. How would you use the Minzer index? MCV divided by red blood cells in million. For example, if you have a child with MCV 65 and the number of red blood cells in millions 4.5, the result will be 14. So this is more than 13. This is suggestive, only suggestive of iron deficiency anemia. On the other hand, if you have a child with MCV 65 and the red blood cell count is 5.5, the result will be 11, less than 13. This is suggestive of beta thalassemia trait. So this is not a diagnostic tool. It is used only as a screen by looking at the CBC. If the initial labs are suggestive of thalassemia, the next step is electrophoresis. If hemoglobin A2 is normal, this is alpha thalassemia trait. If hemoglobin A2 is elevated, this is beta thalassemia trait. Microcytic anemia. The size of red blood cells is larger than the size of the nucleus of mature lymphocyte. If you have a case with macrocytic anemia, there are two possibilities, megaloblastic or non-megaloblastic anemia. Megaloblastic anemia, simply the neutrophil will be hypersegmented, and the possibilities are folic acid deficiency, B12 deficiency, or both. We have to test both together. If B12 is deficient, we have to treat but consider underlying causes. If folic acid is deficient, we have to treat and retest after the treatment. If both are low, we have to refer to a pediatric hematologist and the treatment of the cause. Non-megaloblastic anemia means with no hypersegmentation of neutrophil. Next step is to order retic count. If the retic count is low, most likely is because of hypothyroidism or hepatic disease. If it's elevated, possibilities are hemolysis or hemorrhage. If you have a child or infant presenting with pallor macrocytic anemia, consuming excessive amount of goat milk for any reason, what is the most likely cause? This is a classic presentation of folic acid deficiency. This is particularly high yield. Macrocytic anemia, café au lait spot, short stature, thumb or thumb and radial anomalies, abnormal male gonads, microcephaly, eye anomalies, structural renal defects, developmental delay, abnormal ears or hearing, elevated fetal hemoglobin, markedly elevated erythropoietin, thrombocytopenia, leukopenia, and normal adenosine deaminase or ADA. What is the most likely diagnosis? Fanconi anemia. Another patient with macrocytic anemia, short stature, craniofacial dysmorphism, triphalangeal thumbs or other thumb anomalies. What is the most likely diagnosis? Diamond black fan anemia. Diamond black fan anemia associated with macrocytic anemia, short stature, craniofacial dysmorphism, and thumb abnormalities. It is a pure red blood cell aplasia, so other cell lines are usually normal. Increased adenosine deaminase or ADA. Remember, in Fanconi anemia, the ADA was normal. Normal B12 and folic acid. Remember, in any case of macrocytic anemia, we have to test B12 and folic acid. Elevated serum iron, and the treatment usually is steroids. This table is to differentiate between Fanconi anemia and diamond black fan anemia. In Fanconi anemia, all bone marrow cells are affected. It is aplastic anemia. Diamond black fan anemia, it's a pure red cell aplasia with normal white blood cells and platelets. Normal ADA in Fanconi anemia, elevated in diamond black fan anemia. Both are associated with macrocytic anemia, elevated fetal hemoglobin, thumb anomalies, and short statures. Skin changes are common in Fanconi anemia. Café au lait spots is not common in diamond black fan anemia. Normocytic anemia. The MCV is more than 70 plus age and less than 100. The size of red blood cells is equal to the size of the nucleus of mature lymphocyte. An 8-week-old infant with hemoglobin 11. Normal MCV and retic count. Normal direct and indirect bilirubin levels. Negative direct antibody test. The infant's hemoglobin was 15.8 at birth. What is the most likely cause of hemoglobin drop? Physiologic anemia of infancy. Explanation of physiologic anemia is because of increased oxygen and adult hemoglobin after birth. This will downregulate the erythropoietin and will lead to decrease in hemoglobin level. The nadir is around 8 to 12 weeks of age. Then the hemoglobin starts to correct again later on in infancy. This is in full-term infancy. Preterm infant is earlier, is around the nadir is around 3 to 8 weeks of age, and is exacerbated more in preterm infancy because of frequent phlebotomies and frequent testing. If you have a child between 1 and 3 years of age, gradually increasing pallor, no symptoms or fatigue, asymptomatic, and hemoglobin level 5 to 7 grams, and normal MCV, normocytic anemia, and the retic count is low, what is the most likely diagnosis? Erythroblastopenia of a childhood. This is the most likely diagnosis. The keywords here, the most common age, 1 to 3 years of age, increasing pallor, usually no symptoms, and the hemoglobin always low, and can be as low as even 2 grams, and the child doesn't have symptoms. A normal MCV, low retic count. And if you worry about diamond blackfan anemia, in this case, no congenital anomalies, no short stature, and the ADA will be normal. The treatment of that is reassurance. Blood transfusion is rarely required. Again, to emphasize the difference between transient erythroblastopenia of childhood and diamond blackfan anemia. Both of them, they are associated with pure red cell aplasia. Here is acquired, here is congenital. The most common age 1 to 3 years of age, 2 to 3 months in case of diamond blackfan anemia. No congenital anomalies, and here multiple congenital anomalies. Normocytic anemia, macrocytic anemia in diamond blackfan anemia. Normal fetal hemoglobin, normal serum iron, normal EDA. Here is elevated hemoglobin F, elevated serum iron, and elevated EDA. The treatment here is reassurance. Transfusion rarely required. Here transfusion steroids are always required. Hemolytic anemia. If you have a patient with jaundice, splenomegaly, gallstones, mild to moderate anemia, increased retic count, increased mean corpuscular hemoglobin concentration, MCHC, and small red blood cells with loss of central pallor. As you see here in the peripheral smear, the red blood cells here is smaller than the size of the nucleus in lymphocytes and with loss of central pallor. It is hyperchromatic plus hyperbilirubinemia. What is the most likely diagnosis? Hereditary spherocytosis. Confirm the diagnosis with osmotic fragility test. Another case scenario, African American or Mediterranean, presenting with dark urine, sudden onset of pallor and anemia. Recently was started on medicine, for example, Bactrim for UTI. Peripheral smear is positive for Heinz bodies. High retic count, hyperbilirubinemia, splenomegaly, decreased haptoglobin. And you suspected G6PD from the clinical presentation, and you ordered G6PD activity during the active episode of hemolysis, and it came back negative. What is the most likely diagnosis? G6PD deficiency is the most likely diagnosis, even with negative enzyme activity. Why? Because this test was done in the wrong time during active hemolysis. During active hemolysis, most of all the red blood cells with deficiency of G6PD are already destroyed. So when you do this test during this time, it will give you false negative results. Why? Because the body will compensate to produce more immature red blood cells, more reticulocyte, and these cells, they have increased G6PD enzyme. So this will give you false negative results. So the best time to do the testing for G6PD during remission, not during active hemolysis. An African American or Mediterranean infant presenting with pain and swelling in hands and feet for 1 week is having pallor and icterus, looking pale and yellow, low hemoglobin 7 grams, low hematocrit 28%, and a high reticulocyte count. You are looking at the peripheral smear showing elongated red blood cells, target cells, and red blood cells with Howell Jolly bodies. What is the most likely diagnosis? Sickle cell anemia. The buzzwords here are pain and anemia. Buzzwords in cases of sickle cell anemia. If you have a child with pain and swelling in hands and feet, dactylitis. If you have a child with history of sickle cell anemia presenting with shock, severe anemia, splenomegaly, and high reticulocyte count, what is the most likely diagnosis? Splenic sequestration. If you have a child with history of sickle cell anemia presenting with fever, malaise, and rash, severe anemia, and low reticulocyte count, what is the most likely diagnosis? Aplastic crisis. The difference between aplastic crisis and splenic sequestration: in case of sequestration, the retic count is elevated. In case of aplastic crisis, the retic count is low. Sickle cell anemia plus fever, what is the most likely cause? Infection with encapsulated bacteria, especially Streptococcus pneumoniae. If you have a child with sickle cell anemia presenting with chest pain, fever, cough, tachypnea, leukocytosis, pulmonary infiltrates in the upper lobes, what is the most likely diagnosis? Acute chest syndrome. This disease is very serious, and if it's not treated in timely manner, the patient can develop acute respiratory distress syndrome. If you have a child with sickle cell anemia presenting with persistent fever and bone pain, what is the most likely cause? Osteomyelitis. The most common organisms are Staphylococcus aureus and Salmonella. Swelling in hands and feet or dactylitis, or what is well known as vaso-occlusive crisis. What is the best next step? Aggressive hydration and pain control. Morphine is the drug of choice for pain control. Splenic sequestration means severe anemia, shock, elevated retic count, splenomegaly. What is the best next step? Next step is transfusion of packed red blood cells. Aplastic crisis means severe anemia in a child with sickle cell anemia and low reticulocyte count. What is the best next step? Transfusion as needed. Sickle cell anemia plus fever means infection with encapsulated bacteria, specifically Streptococcus pneumoniae. Next step is blood culture, chest x-ray, antibiotics, or third generation cephalosporin. Acute chest syndrome. Next step is acute chest syndrome is a medical emergency. Immediate admission to the pediatric ICU with ABG, chest x-ray, oxygen, transfusion, pain control, antibiotics, for example, ceftriaxone or cefuroxime and macrolides. If you have a child with sickle cell anemia and suspected osteomyelitis, the best next step is imaging studies. The most sensitive is MRI, blood cultures, and IV antibiotics. A child with history of sickle cell disease presenting with symptoms of stroke, for example, convulsions or hemiparesis, what is the best next step? Transfusion. A previously well 17-year-old adolescent girl with new onset of exercise intolerance. In physical examination, she's afebrile with a heart rate of 123 beats per minute, a blood pressure of 110/76. She appears pale and fatigued, has slightly ecteric icterus, jaundice, and 2/6 systolic murmur. Her examination is otherwise unremarkable. White blood cell count is 10,000 and her hemoglobin is very low, 3.5 grams per deciliter. MCV is within normal limit. Platelet is within normal limit. Retic count is very elevated, 36%. What is the best next step? The most likely cause of her anemia is autoimmune hemolytic anemia. So it is very important to immediately test the patient with direct antibody test, start prednisone, and transfuse the least incompatible packed red blood cell unit. Again, to emphasize the importance of this illness, if you have a child presenting with sudden onset of fatigue, pallor, jaundice, tachycardia, high retic count, and positive direct antibody test, this is autoimmune hemolytic anemia. It is a life-threatening hematologic emergency. Neutropenia. Neutropenia, ANC less than 500 plus fever. What is the best next step? Admit for blood cultures and IV antibiotics. Neutropenia for 1 week every 3 weeks with gingivitis, pharyngitis, or skin infections during nadir. What is the most likely diagnosis? Cyclic neutropenia. It can be associated with gingivitis, pharyngitis, or skin infections during nadir. In order to establish the diagnosis of cyclic neutropenia, we need to order CBC 2 to 3 times per week for 6 weeks. And the treatment here is prophylactic granulocyte colony stimulating factor during nadir and immediate attention with fevers. Severe neutropenia from birth, oral ulcers, tooth decay, recurrent infections, and ANC is low all the time. What is the most likely diagnosis? Castman syndrome. The key points here are severe neutropenia from birth, congenital, and ANC is low all the time. The treatment here is bacterium prophylaxis, granulocyte, colony stimulating factor, hematopoietic stem cell transplantation. Skeletal abnormalities, steatorrhea or pancreatic insufficiency, weight loss, short stature, recurrent infections, dry skin, and pancytopenia. What is the most likely diagnosis? Shwachman-Diamond syndrome. Of course, we have to ask this question, is it cystic fibrosis? In case of Shwachman-Diamond syndrome, you will have normal sweat chloride test, no pulmonary symptoms, and the patients with Shwachman-Diamond syndrome, they do have pancytopenia, not with cystic fibrosis. Bleeding disorders. Recent viral infections, low platelet, petechiae, ecchymosis, and large size platelets. Other cell lines are normal. What is the most likely diagnosis? Immune thrombocytopenic purpura or ITP. The treatment is observation, no treatment. Most of the experts recommend observation with no treatment regardless the number of platelets. ITP can be confused with Wiskott-Aldrich syndrome. In Wiskott-Aldrich syndrome, the platelets are small, associated with recurrent infections and eczema. And in case of ITP, the platelets are large and no recurrent infections, no eczema. Full-term male newborn with maternal immune thrombocytopenic purpura, for which his mother received IVIG, with the last dose given 3 weeks before delivery. His blood type is B, and at birth he had platelet count of 15,000 only, very low. On physical examination, he is well appearing without any evidence of bleeding. What is the best next step? To give the newborn IVIG. Newborn with severe thrombocytopenia and maternal history of ITP or any other autoimmune disorder. This is neonatal ITP and the treatment is IVIG. Another condition, different, newborn with severe thrombocytopenia, maternal history of prior children with neonatal thrombocytopenia, but no maternal history of autoimmunity. This should raise the concern for neonatal alloimmune thrombocytopenia. The treatment here is different, is transfusion of maternal platelets. Bleeding after birth, for example, after circumcision, thrombocytopenia, absent radius. What is the most likely diagnosis? TAR syndrome. Hemangioma, thrombocytopenia, and consumptive coagulopathy. What is the most likely diagnosis? Kasabach-Merritt syndrome. Any infant with unexplained thrombocytopenia with or without evidence of DIC should be evaluated for visceral or hidden vascular lesions, especially of the liver or spleen. Corticosteroids most commonly used in treatment of Kasabach-Merritt syndrome. 60-day-old baby, boy or girl, was born at home, exclusively breastfed. Presents with excessive bleeding from the umbilical cord and blood in stool. What is the most likely cause? This baby was born at home, did not receive the routine vitamin K after birth, and presenting with excessive bleeding from umbilical cord and blood in stool. This is vitamin K deficiency or hemorrhagic disease of newborn. Laboratory finding prolonged prothrombin time, and the treatment is vitamin K. A 3-day-old boy with excessive bleeding after circumcision. What are the best initial diagnostic studies? CBC, PT, and PTT. CBC came with a normal limit, and the screening coagulation study showed PT is normal and PTT is prolonged. If you have PTT is prolonged, what is the best next step? Next step is to order factor 8 assay. If factor 8 assay is deficient, this is hemophilia A. Normal value between 50 to 150%. If is more than 5% is mild, between 1 and 5 is moderate, and if is less than 1%, factor 8 assay, this is severe hemophilia A. 15-year-old girl presents with pallor, fatigue, recurrent episodes of epistaxis, and excessive menstrual bleeding. What are the best initial diagnostic studies? CBC, PT, and PTT. All are normal. What is the next step? You decide to order von Willebrand factor activity, and it came back low. So this is a von Willebrand disease, and very important to know that 25% they may have prolonged PTT. The difference here between hemophilia A and von Willebrand disease, I will call hemophilia AA and von Willebrand disease V. So in A, it is X-linked recessive in boys. In V is autosomal dominant, affects boys and girls type 1, which is the most common type, 70 to 80%. Normal CBC in A, normal CBC in V. In most patients except type 2B may have low platelets. Prolonged PTT, and the PTT is often normal but can be prolonged in V. Bleeding time is normal in A. Bleeding time is prolonged in V. Von Willebrand factor activity is usually normal or elevated in A. In V, it is usually low. Treatment here in hemophilia A is factor 8. In von Willebrand, the treatment is desmopressin. 18-year-old with recurrent epistaxis, easy bruising, gingival bleeding, normal count and morphology of platelets. Platelets are normal. Platelets agglutinate to ristocytin, poor platelet aggregation with adenosine diphosphate, epinephrine, and collagen. What is the most likely diagnosis? Glanzmann thrombasthenia. Another case scenario may be mistaken with this case. 18-year-old with prolonged bleeding time, low platelet, giant and abnormal platelets. Platelets do not agglutinate to ristocytin, but agglutinate to ADP, epinephrine, and collagen. What is the most likely diagnosis? Bernard-Soulier syndrome. Very important to know the difference between both, because both of them they can present the same with recurrent epistaxis, easy bruising, gingival bleeding. In Glanzmann, the platelets normal number, normal count, normal shape. And the platelet, because they are normal to remember, they are able to agglutinate to ristocytin. In Bernard, the platelet number is low and the shape is abnormal. They are giant and abnormal platelets, and platelets do not agglutinate to ristocytin. So Glanzmann, again, normal platelets, platelets agglutinate to ristocytin. Bernard, platelets are abnormal and do not agglutinate to ristocytin. Pediatric oncology. Red flags of brain tumor: morning vomiting, always abnormal, occipital headaches and neck pain, always abnormal, gait disturbance, new onset, head tilt or torticollis. These symptoms are commonly associated with posterior fossa tumor, ataxia, dysmetria, and nystagmus, commonly associated with tumors in cerebellum or tumors invading the cerebellum. Disconjugate gait, hemiphyseal weakness, hemiparesis, Horner syndrome, which is ipsilateral meiosis, ptosis, and anhidrosis, commonly associated with brain stem tumors. In any child with suspected brain tumor, the next step is brain MRI if the child is stable. If the child is unstable, send immediately to the ER for CT scan and stabilization. A 4-year-old presents with fever, bone pain, limping, joint swelling, enlarged livers and spleen, low platelets, and low white blood cell count. What is the best next step? Bone marrow biopsy. The most likely cause is leukemia. 15-year-old presents with cough, chest pain, shortness of breath, large neck lymph nodes. What is the best next step? Chest X-ray. You are concerned about lymphoma and mediastinal mass. You have a child presenting with polyuria, polydipsia, severe and persistent seborrheic dermatitis like rash, lytic bone lesion, oral or ear discharge, conductive hearing loss, and post-auricular swelling. What is the most likely diagnosis? Langerhans cell histiocytosis. Painless abdominal mass. Or another presentation: abdominal pain, emesis, weight loss, anorexia, fatigue, bone pain, limping, periorbital ecchymosis and proptosis, opsoclonus, which is a fast and a quick movement of the eye, myoclonus, twitching of group muscles, diarrhea, elevated homovanillic acid and vinylmandelic acid in urine. What is the most likely diagnosis? Neuroblastoma. Neuroblastoma can present with painless abdominal mass or these symptoms. 3-year-old female was coming to the clinic because of runny nose, congestion, and low-grade fever for 2 days. On physical examination, vital signs are normal. Nose is runny and the throat is erythematous. On abdominal examination, there is a significant, large, and solid mass in the left flank. Her UA was normal. What is the best next step? Abdominal ultrasound. This patient in the previous slide was diagnosed with Wilms tumor, which is a painless abdominal mass usually discovered by the caregiver at home. Hematuria, hypertension can be associated with hemihypertrophy and Beckwith-Wiedemann syndrome. 72 hours after chemotherapy, a child rapidly developed lethargy, edema, dysuria, flank pain, low urine output, hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia, elevated BUN and creatinine. What is the most likely diagnosis? Tumor lysis syndrome. Treatment of tumor lysis syndrome: aggressive IV hydration, sodium bicarb, allopurinol, IV infusion of glucose plus insulin for treatment of hyperkalemia. If these therapies fail, the next step is dialysis. New onset dyspnea, facial swelling, head fullness, cough, arm swelling, chest pain, dysphagia, orthopnea, distorted vision, hoarseness, stridor, headache, venous distension of the neck and the chest wall, facial edema, upper extremity edema, mental changes, plethora, cyanosis, papilledema. Symptoms are aggravated by bending forward. What is the most likely cause? Superior vena cava syndrome. Superior vena cava syndrome commonly associated with malignant mediastinal tumors. This table for common side effects of chemotherapy: anthracycline, cardiac toxicity, alkylating agents, gonadal dysfunction, bleomycin, pulmonary fibrosis, cyclophosphamide, hemorrhagic cystitis, cisplatin, hearing loss, and peripheral neuropathy, methotrexate, oral and GI ulcer, and bone loss. I will conclude this presentation with few buzzwords. Microcytic anemia plus low ferritin. This is iron deficiency anemia. Microcytic anemia plus normal or high serum ferritin, low serum iron. This is anemia of chronic disease. Microcytic anemia plus normal or high ferritin plus high iron plus normal hemoglobin A2 in electrophoresis. This is alpha thalassemia. Same presentation like alpha thalassemia trait, but the hemoglobin A2 is elevated in electrophoresis. This is beta thalassemia trait. Microcytic anemia plus basophilic stippling of red blood cells plus elevated free erythrocyte protoporphyrin level. This is lead toxicity. Microcytic anemia plus elevated serum iron plus erythroblast with 8 iron deposits around the nucleus. This is sideroblastic anemia. Macrocytic anemia plus goat milk, folic acid deficiency. Macrocytic anemia plus strict vegan, B12 deficiency. Macrocytic anemia, thumb anomalies, skin changes or cafe au lait spots, aplastic anemia or bone marrow failure, elevated fetal hemoglobin and normal ADA, Fanconi anemia. Macrocytic anemia, thumb anomalies, pure red cell aplasia, elevated fetal hemoglobin, elevated ADA and serum iron, diamond black fan anemia. Normocytic anemia, no congenital anomalies, means previously healthy, gradually increasing pallor. Pure red cell aplasia means white blood cells and platelets are normal. Normal fetal hemoglobin, normal ADA. This is transient erythroblastopenia of childhood. For more details and comprehensive coverage, see the previous hematology and oncology lectures. This is the end of this presentation. Thank you for listening. Educational purpose and not intended to direct care of any specific patient, please consult your physician or the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.